I'm Dr. Meredith Warner of Warner Orthopedics and Wellness, also the Well Theory and the Healing Soul. And today we're going to talk about a topic that is, of course, near and dear to an orthopedic surgeon, osteoporosis. This is my clinic in Baton Rouge, Louisiana, and it's intentionally designed to sort of promote health and wellness in terms of lighting, space, colors, aromas, etc. We do a lot of hands-on physical medicine with physical therapy, big believers in non-surgical care of the human body. Osteoporosis is very common and far more important than you probably really understand, and definitely more important than was understood when I was initially taught about osteoporosis when I was a resident at Tulane in New Orleans. Osteoporosis turns out to have vast implications for your entire body, to include obesity, insulin metabolism, and brain health. And I'm going to explain why. But what is osteoporosis? So this picture is a scanning micrograph that depicts the microarchitecture of bone. So not to be graphic, but like when you eat chicken, if you crack open the bone and look at it, you've got kind of a hollow cylinder, and inside should be the bone marrow that you would make your bone stock from to get your bone broth, right? And then there's like a rim, or the outside of the cylinder is cortical bone. So the cortical bone is usually a bit denser. And then the spongy bone, or the bone marrow bone on the inside, is cancellous bone. And they serve different functions and have different physical properties. But all of it is dependent upon the mineralization of the bone, the collagen structure of the bone. This is why you can get collagen from bone broth, which is my preferred method of getting collagen, is making my own homemade bone broth. Collagen gives the tensile strength, and we're going to discuss that, but that's the primary protein in bone. And then you've got the minerals that deposit around it, but there's a certain structure that is mandatory to have your bone work properly. And the picture on the left shows you normal bone, and then there's osteoporotic bone. As you can see, with osteoporosis, the bone becomes less dense, weaker, thinner, and not able to withstand normal forces. The picture on the bottom is a conceptualization of a bridge that uses the same features and functions of the human body, called tensegrity, and it's basically the combination of tension with compression to allow us to essentially exist in our environment. So what is osteoporosis? We're going to talk about what it is, the definition, the causes, the risk factors, what are the symptoms, and then how do you diagnose it, and what are the normal treatments nowadays? So, bone health. This is sort of a contentious issue, not contentious, but I want to say maybe confusing or not coordinated issue over the medical industry. Some people think the primary cares are in charge of your bone health. Some people think your OBGYN is in charge of your bone health. Some people think the orthopedists are in charge of your bone health. Some enterprising hospitals have created bone health centers, and those people are in charge of your bone health, whoever they are. And then there's a fracture service with infusion centers. Basically, nobody really knows who's supposed to be in charge of your bone health. I'm just going to tell you what you need to know, because as in much of medicine, you have to advocate for yourself, because the left hand never knows what the right hand's doing in medicine. Nobody ever gets the records they're supposed to get. Nobody ever communicates. I mean, you know how it is. We try to fix it. We try to make it as good as it can be, but ultimately, my philosophy, or what I try to do with all of these educational seminars and the companies that we have, is to empower you to take care of yourself and to know what you need to do and to advocate, and then have the tools, if you do need specialized help, to know to whom you should go speak with. But I'm just going to tell you what you need to know about osteoporosis, and then maybe that'll guide you in your future care.
I have a couple comments. Just excited that you're talking about this because they're currently being treated for it.
Oh, some of the audience is currently being treated for osteoporosis. Yeah, it's very common. I'm not surprised. Okay, so basically think of it this way. Osteoporosis is really bad bone health. That's how I think of it. You can either have good bone, you can have osteopenia, which is sort of not so great bone, where your levels of density are below the normal reference values. You can have osteoporosis, which, think how that sounds. Osteo is bone, porosis. So it's poor bone, but really it just means there's a bunch of pores in it, like it's open, it's not dense. Well below the normal reference values of density. And the reference values are based on the average healthy 20 or 30-year-old human being. But we'll get into that when we discuss diagnosis. Osteomalacia is like a diseased bone where there's terrible mineralization. It's just like soft and squishy bone and it's not quite right. And then osteodystrophy, that's when you have abnormal changes in growth and formation of bone. I put the images of the brain. You might be wondering why, because I really want you to understand in this talk how important your bone health is to your brain health. So if you want a strong brain when you get older, you got to start working on your bones. And these are things nobody knew before. This is all stuff that's been coming out the past 10 years or so. And it's just now infiltrating into your average ortho's practice, right? But normally honestly, orthopedic surgeons don't think about these things, the huge implications of bone health to brain health. So the purpose of bone in general, what I was taught and what we normally talk about is structural support of the human body, shape of the human body. But it's also the anchoring point for the tensegrity system of the connective tissues, and we're going to talk about that. Protection of your organs, obviously, is very important for movement. It's a hugely important place to store minerals, and your body functions on minerals all day long, every day. And what's the primary storage point where minerals come and go from is your skeleton, your bone. Turns out bone has a huge endocrine function or hormones. So bone is a hormonal organ, and we never used to think of it that way, but now we know it really is. Your bone talks to other structures and systems in your body on an ongoing daily basis and is very, very important to systemic functionality. Obviously, the bone marrow produces blood cells. That's your primary place to make stem cells, things like that. And then, of course, it gives us something to do in the operating room. We like to fix broken bones, for instance. So I put this picture of a deadlifter, power lifter, because if you think about it, it's pretty amazing that the human body is able to adapt and overcome and do things like powerlifting. Now, how is that possible? How can you possibly overcome gravity like this and be an upright human being? And it comes down to your bone and its connections to the skin and everything in between. So the traditional function of bone we think of as movement and structural support, which of course it does do that. The attachment point of all of your movement units, so your biceps, your triceps, are going to attach on bone, right? And they're going to attach to bone by way of connective tissue attachment points. Every joint in your body is comprised of bone, cartilage, the surrounding connective tissues, and the movement units. Each one has its own form and function. We've talked about that in previous talks. Every bone has a tension, meaning withstanding stretch forces, and a compression, withstanding load, axial load, like weight forces, okay? So tension and compression capabilities. And then, believe it or not, there is a very strong neural network inside a bone, strong attachments of the bone to the brain, strong attachments of the muscle to the brain, strong neural attachments to the bone to the muscle. You get where I'm going with this. You are not just bone with a brain walking around on top of it. It is all connected. And the primary function of the brain, if you think about it evolutionarily speaking, was to enhance our ability to move. Most of the brain is associated with that function, okay? So movement is where this all started, to be mobile. So we're not plants. We don't just sit in one place in the earth, create our own fuel source, and that's it, and rely on photosynthesis. We are moving organisms and have to be able to move. That movement has to have a purpose and has to be able to start and stop, etc. And that is under neural control. So there is a very intense and strong connection between your brain and your body and your bone. Okay. The tensegrity. So I love this concept, and I'm going to give you a little bit of the history of it. But think of it as this slide tells you it is. It's islands of compression within a floating and balanced sea of tension. So if you think about it, we are upright beings in a gravitationally managed world, okay? How is that possible? How do we not just smush down and become pancakes on a daily basis? How do we maintain our upright positioning and the ability to move? And how do people do things like backflips and trapeze art and lift dead weights and things like that? And it's all because of these very intricate tensile connections between the compressive points of the bone. So just like you've got these pieces of steel suspended in cables, somehow defying gravity, that is how your human body works too. It's very architectural, has to do with physics, force vectors, and basically a very finely balanced amount of tension to support the compressive load. So like your spinal column does this, your femur does this, your pelvis does this, and it's really kind of a beautiful thing if you start to think about it. Let me get into it a little bit more now. So this concept of tensegrity actually came from this gentleman in the top right. He was a very famous architect, Buckminster Fuller, and he sort of combined the concepts of biology with architectural and came up with this tensegrity movement, if you will. So it's basically components of compression in a building or a bridge in a network of continuous tension. So suspension bridges, the Golden Gate Bridge, think of that. All of the newer, fancier bridges and buildings coming out, that's all based on his work of tensegrity, of combining tension with compression, which guess what? Much like most things that we think are super cool, and how did somebody think of that? And oh, that's so techie. Really, it's based on biology, stuff that's existed in nature that people are just now figuring out. Bone handles compression and some tension, like we said. The primary ability to withstand tension, stretch, hanging force is going to be from your connective tissues, the other connective tissues, the ligaments, the tendons, okay? And then like joint capsules and things like that. So the bone gives you the scaffold for the whole body. The connective tissues connect all of these disparate elements in all different planes. So you've got connective tissue going across, diagonally, spiral, up, down, throughout your body. You are just filled with connective tissue, holding everything together, attached to your bone so that you can move in space. So it's pretty fabulous. So this picture on the bottom right was created in 1948 by another gentleman who is equally, I guess, attributed with the whole concept of tensegrity, along with Buckminster Fuller. He was in the 40s or 50s. But this sculpture was called the XP sculpture, and was one of the first pieces of art using this concept of islands of compression in a sea of tension. Okay, and then above it is another structure that shows you these beams just going up into space, seemingly, again, defying gravity somehow. And it's because the force vectors of the tension on the cable are attached in such a way to the compressive loads that it can all exist in space, even despite gravity. So tensegrity allows your body to withstand many forces from many multiple directions, okay? If you were just a steel beam sitting up in space, certain forces you would not be able to withstand and you would just fall over and collapse. But because we are a combination of compression with tension, because the bones handle both compression and tension, and they've got the attachment points of the collagens, we can handle wind, we can be balanced, we can twist, we can move with things, we can stand on shaking earth and not fall over. Tensegrity relies on minimal materials, so because of the ability to combine tension with compression, you don't have to have massive, huge globs of steel or bone, okay? So you can't, a brick building relies just on the axial load, right? But if you begin to bring in the concepts of tensegrity, then all of a sudden you can build taller buildings with less weight, and it doesn't just rely on the axial load and the ability of the bricks to withstand load after load after load, okay? That's how your human body is built. It's strong and it's flexible. So just start thinking of the human body as this very complicated, beautiful architectural design, and the fundamental property of being able to handle all of the movement in space and withstand gravity and to be able to achieve what we do comes down to the structure of your bone. This is why osteoporosis is a scourge. It's really undertreated. It's very much underdiagnosed. And I think in the future, probably the next 10, 15 years, you'll start seeing drugs being created based on bone molecules to help with cognition and things like that. And I'll explain why soon.
Is there any effect of like scoliosis, tensegrity? How does scoliosis affect the tensegrity? The
question is, how does scoliosis affect tensegrity? It does, and in very dramatic ways. And I've got some images coming up of the spine that show you how it works. So like when I see people with scoliosis in my clinic with back pain, we treat most of it, really all of it, non-operatively. And all you have to do is have physical therapists that really understand this concept, and they can find the cables or the tight pieces of connective tissue and lengthen those, and find the lengthened or loose pieces of connective tissue or cables and tighten those. And so scoliosis is not just a deformity like this. It's not just a coronal plane deformity. It is also a rotational deformity. So you have to work on certain strength in one way of rotation and then stretch the other way of rotation to try to balance out and get those forces working better. And then, like everything else in the human body, your body does have the ability to adapt and overcome, even with a deformity like scoliosis, as long as you've got a team that really understands it and can work with you on it. Yeah, so just to bring this home, all of these geodesic domes that you see, the Dali Museum, the Spaceship Earth at Epcot in Florida, all of these exist only because of this concept that came about, the tensegrity concept in architecture. And here's some images of the hip bone, which is one of the structures that we look at with a DEXA scan, a bone scan, to see if you have osteoporosis, and one of the most commonly fractured bones in older people, and a huge cause of death in older people, okay, is a hip fracture. The hip, you can see this left picture with the green and red lines, shows you that part of that bone is designed and has the microarchitecture to handle significant compression loads or the weight of the body as you walk and stand. And then the other part of the bone is designed to withstand connective tissue and muscle pull. So you see on the right side, I don't know if you can see it, but the greater trochanter there is where your hip muscles, your part of your butt muscles attach that keep you from falling over to the side during your walking. So every time you step with one leg, the only reason you don't fall over is because of the tension applied to your hip bone from the muscles that attach to the pelvis and the torso that keep you from falling over. So it's a very finely tuned, balanced system, but each bone has some compression ability, some tension ability, and if it gets messed up, that's when you get breaks and fractures. One of my initial cases when I was taking the boards, the first time to become an orthopedic surgeon, I had a patient who had a stress fracture through the hip. And if you get a stress fracture on one side, the compression side, you could potentially sometimes treat that non-operatively. But if you get a compression fracture through the tension side, that has to have surgery because tension, the bones are weaker in tension. So if you have weak bone and then you have a little crack in the side that's handling tensile forces, it's more likely to go on a catastrophic failure than bone that's under the compressive load. So all of this matters when it comes down to daily function and then bone health and things like breaking bones. I put this picture in. I don't know if anybody out there knows what the picture on the right is. If you do, we'll give you a prize or something. But the left side is a scanning electron micrograph, a depiction of the microarchitecture of your cancellous bone. Now, what does that look like? Coral, all kind of things in nature, right? Because certain structures work best in nature to withstand the forces of gravity and the spin of the earth and things like that. And the tensegrity structure turns out to be one of them. The picture on the right is the Borg cube from Star Trek, which I think looks remarkably similar to the microarchitecture of bone. So here's the spine. So back to the scoliosis question. Here's multiple images of the spine and how it might play into this whole concept of tensegrity and why your bone strength is so important. The picture on the left is showing you various areas of pool of muscle, okay? And these are very common locations of pain. So if you have weak bone, you probably have weak attachment points of these muscles, and it's very easy to get postural deficiencies and very easy to have pain. Weak bone hurts. So a lot of people will get, for instance, in knee arthritis, if you didn't get my knee arthritis talk before, one of the things we see when you MRI somebody with knee arthritis is underneath the subsurface, right beneath the cartilage in the knee joint, there will be areas of fluid or what looks like bone bruising. And what that is showing us is very small fractures through that microarchitecture of the cube I just showed you, and that's highly associated with vitamin D deficiency. And that is also associated with pain. So weak bone leads to weak muscles, weak tensile attachment points. Your tensegrity gets messed up and you start to have pain. Because all of these triangles of pull are supposed to be very balanced, very equal, and function together with the spiral ability of the spine during movement in space and fighting gravity on a daily basis. The top right picture shows you the compressive load, so the vertebral bodies are withstanding compression and they bend a little bit and rotate a little bit about the discs, but the posterior bony elements of the spine have very strong connective tissue attachments and allow you to withstand tensile stress. And I'm going to show you where that matters when we look at a stronger image of like a deadlifting pose. Okay. So basically, osteoporosis will ruin the ability of your body to balance and have that function of tensegrity. You will lose the ability to withstand stretching forces and the pressing forces, so compression and tension. You won't be able to absorb shock as well, and then there's going to be limited self-repair capacity of the bone. The human body is constantly repairing itself, just like you maintain your car, just like you maintain your house, just like you keep cleaning your house because on a daily basis it gets dirty. You have constant maintenance going on in the human body. And osteoporosis changes that ability. Your body is no longer able to repair itself adequately, and so problems propagate in the bone, and that's when you get fracturing, compression, pain, deficiencies, etc. You change the microarchitecture. The cortical, the outside rim of that cylinder, the bone marrow we talked about, the cortical part becomes thinner and it widens out, and the spongy bone deteriorates on the inside. All of this, as you could imagine, would change your ability to move in space and your ability to withstand forces. So here's another great model of a tensegrity structure. So you would wonder, how is it possible for that bridge component, and there are bridges shaped like this, to withstand weight and load? And it's because it seems like it's suspended in space, but it's really not. It's got connective tissue attachments to another structure that is able to withstand compression. And obviously that structure would be flexible and would be able to withstand hurricanes, earthquakes, things like that. That's the beauty of tensegrity. So if you've got porous, brittle bone, that's what osteoporosis is, then you can't withstand these forces. Your bone behavior changes. There's altered signaling. There's altered ability to handle the changes in mechanical forces, and there's altered responses to those changes in mechanical forces. This is when you start to see the little old hunchback start, and the so-called dowager's hump, when your neck sticks forward and you've got this big bump back out between your shoulders. That's from subtle compression fractures that happen over time because the bone is unable to withstand normal loads, okay? And then there's altered spatial organization of the limbs and the spine, like we've discussed already. And then again, the remodeling. So that's just repair. That's our term for repair in bone. We say remodeling. The relationships are damaged, the bone doesn't remodel properly, and perhaps the microarchitecture is created to handle compression when it should have been formed to handle tension. It all just gets messed up with osteoporosis. Okay, so again, this is just showing you complex mathematical models of, the one on the left is for the foot. So somebody sits down and does these complex mathematical models of how each bone withstands a certain amount of tension, a certain amount of compression, which is modified and changed by the strength of the muscle and the connective tissue attachments to it during gait. The right side with the skeletons, the cartoons with a little bit of muscle, is showing you fascial lines, which are very, very important in terms of human body function and pain. So you've got a superficial front line of fascia, a superficial back line, you've got a lateral line, meaning on the side, and then you've got a deeper front line. All this means these are the tensile, the connective tissue that's connecting the compressive skeleton. So the axial load components of the bone are connected to allow you to bend backwards, go side to side. All of that is dependent on the tensegrity of these connective tissue lines of fascia with very intricate and complex connections to the skeletal structure. Bone becomes a force multiplier for you. And it depends on how you load the bone on how it's going to withstand the forces. So that's a picture of a femur, the top right. So if you load it top to bottom like you're standing, it can withstand a tremendous amount of force. But if you load it from the side or twist it, it's much easier to break it. And that's because it's not able to withstand those forces with the torsion and the tension. That's what the connective tissue is attached to it to do, okay? It takes about 900 pounds of force to break a femur. It takes only 740 pounds of force to break a clavicle. Clavicle is the most commonly broken bone in the body. But how you apply that force matters. Is it applied in a twisting way? Is it applied in a bending way? Is it pure compression? Is it a combination of all of those somehow? And these are the things we learn in orthopedics, the mechanism of injury. How did the fracture happen? Because then it helps you determine what's the best way to fix it. Here's some amazing, very high magnification electron micrographs of how bone actually fails. So if you look on the top right, one is in the long axis of the structures of the bone, and one is the cross section, okay, like slices of bread. And it just shows you what happens in the microstructures. You basically get a shear. So it's a combination of tension with compression, and it cracks the bonds. And that's the beginning of how a bone breaks. So really, and then I wanted you to also know about the Haversian canals on the bottom right. So if you think about bone, you see a bone, then you go a little bit smaller and you've got what are called Haversian canals. And that is the functional unit of bone in terms of biology. Then it goes down to collagen, and then it goes down to the nanostructure of the collagen and the mineralization and deposit of mineral on the collagen. So the Haversian canals, those are tubes of lamellar bone, and inside of each tube, and these are in line and parallel with the surface of the bone, inside each tube are blood vessels, and guess what? Nerves. So there are nerves throughout bone at the microscopic level connecting everything together, and guess where all the nerves end up? Your brain. So deadlift, let's talk about this. So you could see on the picture the guy who's flexing, and just for the record, I don't know why anybody would want to do this, but a lot of people do, and it's pretty cool. It's amazing that they are able to do it. I personally don't ever want to lift that much weight, but if I wanted to, probably not me, but this guy, I could probably lift maybe a tenth of that if I worked really, really hard at it for a really long time. But you could see by all of the muscle striations how much tensile force is being applied to his bones to withstand that axial load being created by that massive amount of weight he's lifting. So think about this, look at his knees. Think about the tensile forces being applied to the patellar tendon as it attaches to the tibia and the quadriceps muscle, which are going to be used to bend the joint, to let his legs straighten, to let him pull that weight up. Meanwhile, in the spine, that superficial and deep, the back line I talked to you about, and those interconnections on that tensegrity model between the spinous processes of the spine and then all of the posture muscles in the back part, same thing. They're going to be applying a ton of tensile force to help overcome this compressive load to be able to do a deadlift. So the deadlift it's one of the great lifts out there if you're interested in bone health and creating strength. This is one of those multi-movement, multi-muscle group fundamental lifts that we should be able to do. Now, this lift has to be done properly or you can hurt yourself, obviously. So this is one you want to start doing with a physical therapist or a personal trainer or something like that. But I just put this in here to show you the very significant tensile forces that the human body is able to withstand and overcome, and then also the compressive loads that we're able to withstand and overcome as well because of this tensegrity. And none of this would be possible if that guy had osteoporosis. He would just crack and break everywhere. So bone strength is hugely important for muscle strength. And if you've listened to any of my talks, you know that muscle strength is very important to prevent fragility, to help your cognition, and to help you age well, which is really the goal of everything, correct? So let's talk about mineral storage just really briefly. This is where we store calcium, phosphate, etc. The organic bone matrix is a location of storage, and calcium, phosphate are important in things like nerve conduction, important in things like muscle contraction, intracellular communication, blood clotting, enzymatic activity. Phosphate's an integral part of ATP, which is a primary energy component of the human body. So your body stores this stuff and releases it as it is necessary, okay? Just like your refrigerator stores food and lets you have food as you need it, your bone is doing that for your body in terms of minerals. And we use minerals all the time. Just like plants do, we do as well. So this is all under hormonal control as well. And the bone itself is an endocrine or hormone organ. So parathyroid hormone, thyroid hormone, calcitonin, D3, which is really a hormone more than it's a vitamin. All of these play into bone health. So like when people come see me, I'm checking all of these. If they don't have good thyroid health, I know they're not going to be able to have good bone and muscle health. So everything needs to be looked at in a holistic way for you to really be able to age gracefully and well. Let's talk about the endocrine functions of bone, because this is where really everything is starting to go. A lot of the basic science literature and a lot of work. Turns out the bone, like the thyroid, like the testes, like the ovary, like the pituitary, spits out hormones. All a hormone is a little molecule, typically a protein of some sort, that communicates with systems or organs far away from where it was released. So it's just another way the body talks to itself all the time to get things right and to make sure we function properly. So osteocalcin is a very important molecule that the body makes, and it's only made by osteoblasts. What's an osteoblast? An osteoblast is the bone-forming cell. So osteoblasts, once a stem cell becomes an osteoblast, will just lay down new bone. So as it's doing that, it's also making osteocalcin. Well, it turns out osteocalcin isn't just important for bone health. It's also highly implicated in the regulation of glucose. So it can help control hyperglycemia if you have appropriate amounts of osteocalcin. And it's highly implicated in how the pancreas functions and produces insulin. And then it makes your bones and muscles more insulin sensitive to pull more glucose out of the bone. So osteocalcin is very important for energy metabolism, fat deposition, the ability to withstand hyperglycemia, things like that. But most importantly, it triggers the release of what's called brain-derived neurotrophic factor, BDNF, and this is a very important protein that helps your neurons, your brain cells, heal themselves, communicate better, form new connections, or become plastic, like we say, neuroplasticity, and also helps with cognition, memory, things like that over time. Osteocalcin is very important in how the mineral laydown in bone happens. So you get, think of like a bricklayer again. If you have somebody put brick down and they put the mortar in the wrong place, or it's too thin, or it's too thick, or they glop it all over, it's not evenly applied, your brick wall is not going to be strong. It's not going to be able to withstand time and force. Same thing in the human body. If you don't lay down that mineral deposition, that extracellular matrix just right, things don't work right. Osteocalcin is very important for this. Osteocalcin tells the bricklayer how to put the mortar down, how to connect it all, okay? So it helps with the proper mineralization of the bone. And then things like fibroblast growth factor number 23, very, very important for vitamin D3 and phosphate metabolism. These are one of the molecules that are being looked at strongly by the pharmaceutical industry right now. And then you've got sclerostin. Sclerostin is a molecule that is extremely important in bone health and growth. It is actually inhibitory of bone formation. So remember, you don't always want to be throwing down bone. Then we would just be a big mass of bone, right? You want it regulated. You want just enough bone. The bone needs to be just strong enough. You don't want too much of it. You don't want too much of it in the wrong place. Sclerostin plays into that. It inhibits what's called the WNT signaling pathway, which is very, very important for bone health. And it's crucial to the function of osteoblasts. And we're going to talk about some drugs that affect sclerostin and are being used in terms of bone health. But these are just some of the endocrine functions of bone. The primary one you probably need to remember or think about is osteocalcin. And it has some other functions I'm about to talk about. All right. So this is the cool stuff. So bone in your brain, osteocalcin and BDNF, brain-derived neurotrophic factor. This is a protein that's important for neuron survival, for neuron growth, for neuron maintenance and repair, and for the ability of your brain to form new connections and repair damaged connections, which turns into what? Memory and thinking. So BDNF, hugely important for your cognitive health, for your ability to think, for your ability to remember, etc., and your ability to learn. So without BDNF, you are not going to have the same cognitive powers that you probably want. And one of the ways to increase your levels of BDNF is to increase your levels of osteocalcin. How do you increase your levels of osteocalcin? Don't get osteoporosis, and I'm going to tell you some other things to do, particularly exercise. You notice previous slides that seem to be focusing on muscle and resistance training. Very, very important for osteocalcin and BDNF. What's wrong? Okay, osteocalcin can cross the blood-brain barrier, and it has roles in neurogenesis, meaning the formation of new neurons or parts of neurons, for cognition and for mood regulation. Think about that. So if you've got healthier bone, you're going to have a happier brain too, a calmer brain. All of this is interplayed and interconnected. This is not what we were taught in medical school or residency. You know, we were taught brain-body separation. That's been taught since Rene Descartes, you know, back in, I don't even remember what year, like forever ago. But it turns out there is no mind-body separation. It is one and the same thing and highly interconnected. Osteocalcin stimulates BDNF. That's what you need to get out of this talk. Good bone, healthy bone is going to give you a good and healthy brain. And one of the easiest ways to do this is through exercise, okay? Don't count on some magic pill coming out tomorrow, because even if it did, you know it's not going to be covered. So your primary way to take advantage of this connection and this discovery is resistance training. All right, I put this slide in because this to me is just amazingly fascinating. That is an electron micrograph of an osteocyte, that is a bone cell, and then a neuron. I mean, you can hardly tell the difference. So in terms of evolution, they are essentially the same thing. They just ended up in different parts of the body. This is a paper, the title is Molecular and Cellular Crosstalk Between Bone and Brain, Accessing Bidirectional Neural and Musculoskeletal Signaling During Aging and Disease. So this is stuff that is becoming more and more common in the literature. The very dense connections, neural, remember I told you how the Haversian canals, the microscopic structure of bone, are filled with nerves? There are massive connections between your bone and the rest of your body, and in particular your brain. And you can see all of these dendrites and axons and different little connections going to the cell body. Each one of those is providing communication, input, and changing things as you move in space, as things happen to you, as your body senses one micronutrient deficiency or senses an excess of another, as it senses too much cortisol, too little melatonin, whatever. All of this is communicated and goes back and forth, particularly between the bone and the brain. So a very similar what we call cellular morphology, meaning body shape, between osteocytes and neurons. And then there's cell migration from the bone to the brain. There's bidirectional molecular communication, meaning the brain talks to the bone talks to the brain. And then the proteomes, that is the protein that the osteocytes make and the proteins that the neurons make, have significant overlap. And we see this again and again in studies of degenerative disease of both the bone, osteoporosis, and the brain, dementia. So again, osteocalcin stimulates BDNF, but osteocalcin also has a very strong interplay with vitamin K. Osteocalcin is what is called a vitamin K dependent protein. So vitamin K is the enzyme that is the cofactor required to do what's called carboxylation of osteocalcin. So you either have uncarboxylated osteocalcin or carboxylated osteocalcin, and the way it moves between those two is vitamin K, a vitamin K dependent enzyme, okay? Once it's carboxylated, it can bind this G receptor coupled protein, and that's the most abundant protein receptor that we have. And it's found where? Pancreas, muscle, adipose tissue, brain, bone. So the osteocalcin is binding receptors in all of these tissues throughout your body. Because it's binding in the pancreas, it actually regulates beta cell function, and it'll promote insulin production and also promotes insulin sensitivity in the peripheral tissues, okay? So without osteocalcin, your bone and your muscle won't be able to suck glucose out of the blood like they should. Muscle glucose uptake is enhanced because of osteocalcin, because of this receptor. And then energy expenditure is increased and made more efficient. And then osteocalcin also allows your fat cells to release adiponectin, which is highly anti-inflammatory. And then that also helps to regulate glucose levels and what? Fatty acid breakdown. So unless you have normal levels of osteocalcin, it's going to be really hard to lose weight. And it's going to be really hard to have insulin sensitivity and proper levels of glucose in your blood. All of this plays in together. You can't be healthy without healthy bone. Osteoporosis means less osteocalcin, which means less BDNF, less vitamin K dependent reactions like this, which means altered glucose metabolism, altered fat burning, and then also your insulin sensitivity is diminished. I'm not saying it's the primary reason these things happen, but it is certainly a team player. Okay, so you need to get your osteocalcin levels right. So I'm just going to give you a summary of this slide. That picture on the bottom is what a pathologist would look at if they were looking at your bone under a microscope. The pink swirls is where the mineral is deposited, and then in between are all of the extracellular matrix and all of the cells with all of the neuronal interconnections and whatnot. Osteocalcin is very important for the matrix strength of your bone. So the brick wall is going to fall apart without the mineralization, the correct mortar attaching it all, right? Osteocalcin is very important for telling the bricklayer what to do and how to do it properly. What it also does is it tells the blood vessels to not lay down calcium. So proper levels of vitamin K, proper levels of osteocalcin because of proper levels of vitamin K, mean that you'll have stronger bone and less risk of atherosclerosis, or at least the calcium deposits in the plaquing. Hugely important. When osteocalcin binds to calcium, the ion of calcium, that's why I put 2+, it's got a double positive charge, it causes better crystallization of the hydroxyapatite mineral in the collagen matrix. So think of that like coral. So if your body were a coral reef, you could either have a soft, spongy, pathetic coral reef that nothing could live in, or you've got a strong, vibrant, healthy coral reef. That's what we want. And to do that, you have to have the calcium deposit into the coral structure appropriately to make the coral strong. That's the same thing going on in your bone. And that is dependent on osteocalcin. It also binds to the collagen fibrils. Remember I told you about bone broth being a great way to get collagen into your system? Well, collagen's giving you that tensile strength of bone and is the integral component of tendons and ligaments and things like that. Osteocalcin will actually attach to those collagen fibrils and help them maintain the proper spacing between the fibrils, also the proper spiral, and also the proper diameter of each one. So all of this is under hormonal and neural control as to how your body lays down collagen, how it attaches it to the calcium, how it mineralizes it, where it mineralizes it, what minerals does it put down, and in what levels. So osteocalcin, I can't really emphasize enough, but again, osteocalcin comes from osteoblasts. Osteoporosis is a complete mismatch between osteoblasts and osteoclasts, and there's no balance, and the osteoclasts start to overcome the osteoblasts, and so you're not making as much bone, which means you're not making as much osteocalcin. So vitamin K, very, very important, but also very complicated. I profess I'm still reading about this every day and still learning more and more. It is heavily involved in proper blood clotting. So people that take Coumadin are diminishing their vitamin K's capacity to coagulate blood. And one of the ways, like if you have to do emergency surgery on somebody that's on Coumadin, you give them factor K or extra vitamin K to try to overcome that so that their blood can clot. A deficiency of vitamin K, like if you don't have enough vitamin K in your body, you're going to be more prone to developing atherosclerosis or arterial plaquing with calcium plaques, okay? And then it's heavily involved in bone health, as we've discussed in the previous slides. And this is when you get the carboxylated osteocalcin. And again, it's only carboxylated through the vitamin K enzyme process. That's why it's called a vitamin K dependent protein. And then it's involved in brain health. So it's involved in proper clotting, it's involved in bone health, and it's involved in brain health. Because without proper vitamin K, you don't have proper osteocalcin, which means you don't have enough BDNF. And then it's involved in the creation of sphingolipids, which are very good for being anti-inflammatory and good heart health, and also phospholipids or cell membranes. All this plays in together. But vitamin K, I think, is kind of ignored in the bone world, not in Japan, we'll talk about that. But in the American bone world, we sort of poo-poo vitamin K and don't really talk about it, mostly because nobody really knows how to measure it or what levels to tell you are proper, etc. I'm going to go into it briefly. But you have to have a good vitamin K balance if you want healthy bone and if you want a healthy circulatory system. And if you want a healthy brain, you need to want healthy bone. Okay, so remember, osteocalcin is carboxylated by way of vitamin K. And then vitamin K also limits what's called osteoclastogenesis, or the creation of osteoclasts. Osteoclasts are the big bad cells that come in and chew up your bone. Now, in some cases, you want that. Just like you don't want garbage piling up on your street, like happened probably to a lot of us in cities during COVID and other times recently. You want the garbage men and the garbage companies to come pick it up and take it to the landfill where it can be processed properly. Well, that's what the osteoclasts do. So you do want some ability to chew up bone and spit it out. You just don't want an overwhelming capacity and an uncontrolled capacity to do that, which is what osteoporosis does. And then other vitamin K dependent proteins are listed here. Osteocalcin we discussed, matrix glial protein, glial-rich protein, protein S, growth-specific 6 protein, I mean, on and on and on. Vitamin K, just remember, very important for your cardiovascular health because it limits calcium buildup in the blood vessels. Very important for your bone health because it gives healthy, regulated, proper calcium lay down in your bone. So interestingly, osteocalcin or vitamin K really has been approved to treat and prevent osteoporosis in Japan. Not here, but there. Why? Because one of the primary food sources of vitamin K is natto, which is a fermented soybean. It is the richest food source of vitamin K, the active form, K2. It's about 775 micrograms per 100 grams. I personally have never tasted natto. I do like some soy products, but I don't know if I would like this. Fortunately, we have supplements for such things, and you don't have to eat a bunch of natto. It is found in some aged cheeses as well. But basically, it's a fermented soy thing, and it's formed, like for purposes of supplements and stuff, we use bacteria to form it, because bacteria in your gut as well is one of the other ways to make the active form of K, MK7, the active form of K2. There's also MK4. This is natto. At least that's what the internet told me natto looked like. Now with so much terribly generated AI content, you really can't believe anything you even get on a search anymore. But that's your primary food source if you're willing to eat that. And again, vitamin K is approved to treat osteoporosis in Japan. K1, K2. So K1 is phyloquinone, made by plants. Phylo always means plants, found in the human diet. And then menaquinone, which is made by our intestinal bacteria, and then also found in cheese, eggs, meat, and natto, which are fermented products, which means something's going on with bacteria. It is more bioavailable than K1 for us. Most of your ingested K is going to be gone in a day. This is why you do daily supplements. Or, you know, if you're in Japan, you eat things like this on a daily basis. Okay. Vitamin K is strongly, my opinion, based on all the reading I've done and the basic science I've worked on, strongly related to your bone strength, your bone health, osteoporosis, and your fracture risk. The Framingham study is a very long-term cohort study where they follow a certain group of people over time and then periodically will look at certain aspects of their health and certain variables and factors that play into that and make determinations. A very famous study, it's still ongoing, it's been ongoing forever, and they've determined a lot of things about human health from the study. One of the things they found is that low vitamin K levels are correlated with poor bone mineral density. Lower femoral net density in men and lower spine density in women. And those are the two primary areas of the bone we look at when we're doing bone density scans. In a prospective study of postmenopausal women, which is one of the risk groups for osteoporosis, 200 micrograms a day of K1 along with vitamin D3 and calcium versus a placebo. The group that received the supplements had significant and sustained increases in their bone mineral density and the mineral content of their bone. So this is all good news. These are supplements you can take now to start making your bone health better and not rely on very expensive drugs. The RDA minimum, again, remember the RDA was set after World War II as a bare minimum to keep the soldiers alive. So I'm not sure the RDAs are really applicable nowadays, but it gives us a baseline. 120 micrograms a day for men, 90 for women. Nobody knows what the levels are if you want optimal bone health. This is just so you're not cracking and falling apart while you're walking down the street. Again, K, very important to inhibit calcification of the arteries, okay? And it's an inhibitor of vascular tissue calcification. So if you want flexible, functional blood vessels and strong bone, you want enough vitamin K in your body. So we talked about MK7, MK4, phyloquinone, menoquinone, and then the active forms of K1, K2, shown to increase the impact strength of bone, so that ability to withstand sudden axial load, increases the compressive strength of bone, so the guys that can stand and hold weight all day long, or do military presses, squats, things like that. The women in underdeveloped countries that walk around with gallons and gallons of water on their head, all that's dependent on the compressive strength of bone, highly associated with the K levels in the body. Height loss from vertebral fractures go away or diminish if you've got adequate K in your system. So that progressive hunchback that we always think of little old ladies happening, that is preventable. One of the ways to help prevent that is to have adequate K2 intake. So again, associated with more fractures as well. Warfarin, turns out, long-term use of Coumadin, which is of course generic and very cheap, so many insurance companies prefer Coumadin over some of the newer anti-clotting drugs, is associated with an increased fracture risk because it's inhibiting that conjugation of osteocalcin that we talked about. So you have weaker cortical bone, reduced hip strength, more ability to fracture bone, okay? So keep that in mind too if you or someone you know is on long-term Coumadin. You may want to get your bone density checked. So again, we do not want weak bones, or you end up having bone surgery like this, or you end up in traction, or you end up with a cast, etc. Obviously, you don't want to have fractures, but you also want good brain health, right? And good optimal aging over time. So we've talked about what is osteoporosis, the endocrine function of bone, the mineral storage function of bone, tensegrity, things like that. What are the risk factors for getting weak bone or having osteoporosis? Menopause is one of the number ones. So women that stop producing as much estrogen as they used to are at risk of osteoporosis because there's a high interplay between estrogen and bone health. Poor diet, highly associated with these things. Lack of exercise, we've talked about that, we're going to talk about it again. Time, so it's associated with age. Probably because menopause happens later, and then as we get older, most people stop moving and stop doing anything and they lose muscle, so of course you get weak bone. Smoking, please stop smoking if you're a smoker. I really have never in my life found anything good about smoking, so there's nothing beneficial that I know of. If somebody out there knows of a beneficial smoking thing, let me know, but as far as I know, it's a risk factor for almost everything I talk about, so please quit smoking. More than 14 units, I assume that means a gram, of alcohol per week is correlated, not causal. And then a low bone BMI. So remember, BMI is the way we used to think about obesity. It's being changed now. High BMI means you're obese. Low BMI means you're too thin. So bone weakness or weak bone is actually associated with being too thin, probably because you're not doing enough daily weight-bearing exercise because your body's too light for the bone to care. So menopausal women are at the highest risk of osteoporosis, okay? And what is osteoporosis? It's the uncoupling of the osteoclast from the osteoblast. The osteoclast, the bone chewing cells, overcome the osteoblasts, and then there's diminished repair of the bone on a daily basis, and the bone becomes weaker, brittle, less dense, like those pictures you saw in the beginning. And so you could see this circle with the little tiny, the big, it looks like a big glazed donut, and then eventually it becomes like one of those rings you throw in the pool for kids to dive after. That's that cortical bone becoming thinner and widening out and filling with weaker bone. Your bone has to have the ability to repair and adapt constantly to different needs. So if you started lifting weights now, your bone would become stronger because it would adapt and overcome with the repair capacity. The osteoblasts would eventually put down more bone than the osteoclasts chew up. Osteoporosis messes up that balance. The osteoclast, this is a great electron micrograph of what it looks like. It has a so-called ruffled border, and that ruffled border is where it releases these degrading enzymes or proteolytic enzymes that destroy the bone, and it sucks it up and it recycles the part that your body needs for the osteoblast and spits out the rest of them. Premenopausal, there's a very beautiful balance between the blast and the clasp. Postmenopausal, that diminishes and changes, mostly because of the altered hormonal balance. Osteoblasts are the bone forming cells. Here's one that's becoming an osteocyte within that lamellar structure of the bone, within a Haversian canal. Okay, they come from mesenchymal stem cells, and they produce the extracellular matrix of your bone. Okay, so osteoblasts are throwing down all the stuff that makes bone actually bone. Okay, type 1 collagen and the non-collagenous proteins such as osteocalcin, and then other ones, osteonectin, osteopontin. The extracellular matrix then gets mineralized. The calcium and the phosphate and the magnesium and everything comes in. All of that's controlled by the osteocalcin. And then it's stiffened because of that calcium hydroxyapatite structure. So the mesenchymal stem cells become a bone-forming cell in osteoblasts. The osteoblast spits out the liquid matrix that is going to become bone, sort of the squishy coral. Then the calcium and stuff comes in and makes a coral strong and beautiful. Same thing's happening to us. Osteopontin, briefly, involved in bone remodeling, that repair and rebuilding capacity. It regulates the balance of the osteoblast, osteoclast. It too modifies mineralization, it's just not as important as osteocalcin that we know of today. It's also involved in your immune response. So it turns out healthy bone means you have a better immune system too. D3 is heavily involved in the immune system. Again, everything in the human body is so intricately connected. I don't think you could be a good orthopedic surgeon unless you know all this other stuff, because you can't make the bones and the muscles and the joints work well unless you understand everything else in the body that is affected by and affecting the bones and muscles, the ligaments, etc. It is a pro-inflammatory molecule, the osteopontin. It's very important for cell adhesion when cells attach to different structures to do what they got to do, cell movement or migration, and cell survival. Osteonectin is what's called a SPARC, which means secreted protein acidic and rich in cysteine. Cysteine is in the Wakewell supplement we have, which is part of the glutathione molecule, highly antioxidant. Osteonectin is involved in tissue remodeling, wound healing, again, back to the immune system, right? And then regulation of cell functions. Very high affinity for the calcium ion. So it is one of the things that attracts and binds calcium within that extracellular matrix that the osteoblast just threw down. High affinity for the calcium ions like we talked about, and binds to collagen as well. For the wound repair, it modifies the extracellular matrix which within the structure of the wound that's trying to heal. And then if you have too much osteonectin, then you're going to get a fibrotic wound. Like it won't heal right. It'll be a little bit too much fiber, a little bit too much fibrosis, like scar. So you need a proper balance of all of these things. I just wanted to briefly mention the other hormones of bone, but our primary concern for this talk is osteocalcin. The osteoclast, you saw that picture with a ruffled border, chewing up the bone, cleaning it up, recycling what it can and getting rid of the bad stuff. It is from the same lineage as a macrophage and the monocytes. A macrophage, again, hugely important in the innate and adaptive immune systems. Osteoclast is very dependent on rank L. This is the receptor activator of nuclear factor kappa. It's the ligand, okay? Rank and rank L, if you remember from the talks about inflammation, very strongly associated with the inflammatory system. So anything that upregulates NFKB is upregulating inflammation. So osteoclasts are highly correlated with the levels of inflammation in the body. Osteoprotegerin is a decoy molecule that will block the rank L and rank interaction. So rank's the receptor, rank L is the key to the lock, okay? Osteoprotegerin is a decoy molecule that'll bind rank and keep rank L from binding. But when osteoprotegerin binds, it doesn't have the same effects on bone as the osteoclast would. And in fact, there's some drugs that are being made to mimic osteoprotegerin to help prevent bone breakdown after total joint replacements and things like that. So again, there's a ruffled border that's chewing up the bone. There's a sealing zone that keeps it from chewing up everything around it. And then it's actually spitting out acid to degrade the bone and help get these recycled bits and pieces. So after menopause, most women lose about 3 to 5% of their bone mass per year for the next 5 to 10 years. This is modifiable with lifestyle. What does that mean? Exercise, resistance training, eating the right foods, being healthy, getting to sleep on time, things like that. So you don't have to lose the 3 to 5%. That's just what most of us historically, since this has been studied, have been doing based on our standard American diet and lifestyle, etc. Obese women tend to have higher levels of estrogen because fat cells convert hormones or androgenic hormones into estrogen through the aromatase enzymes, okay? Converts the adrenal androgens into estrogen, highly expressed in the white fat. So what you think of as the outside fat, not the visceral fat. Aromatase inhibitors not only diminish the capacity of estrogen to bind or be formed by this aromatase enzyme, but it also decreases bone mass as well. So a lot of people on aromatase inhibitors have a lot of bone pain, they have a lot of muscle pain, they have a lot of connective tissue pain. Bone loss in men does happen. It doesn't happen as quickly as it does in women, but it is more closely related to their estrogen levels than their testosterone levels, believe it or not. That said, having an appropriate testosterone level is important for both men and women in terms of muscle and bone health. But turns out estrogen is important for bone health for both women and men. So remember, we both have estrogen and testosterone, men and women. It's just certain ratios of each. And then, of course, there's a whole host of other differences, but that's the hormonal main difference. Okay. So the estrogen receptors, this is the important part actually. There are estrogen receptors on the osteoblasts, the bone-forming cells, on the osteoclasts, the bone-chewing up cells with the ruffled borders, and the osteocytes, the actual bone cells that kind of, once bone is formed, they're living in there, and those are the ones communicating and sending out the interfaces. Remember that picture of the osteocyte? It looks just like a neuron. A pro-inflammatory situation will increase the loss of estrogen, and it's also, bone loss is increased by less estrogen. So if you have less estrogen, these estrogen receptors aren't getting triggered, and you have poor, weak bone. This is why menopause matters. So what should you do to avoid the collapse of your skeleton like this? This is showing you a wedge compression fracture of the vertebral body, which is why you see little old ladies start to hunch over, because their spine loses that ability to withstand compressive forces because of osteoporosis, because there's an imbalance between the osteoclast and osteoblast. The bone becomes less dense, brittle, weaker, and can't handle that tensegrity. So the diagnosis, very important. So if you're worried about osteoporosis, you need to go get checked out. Now, I'll tell you this, they're not going to screen you unless you meet certain criteria if you want insurance to pay for it, just FYI. A fragility fracture, by definition, means you have osteoporosis. So like if you're standing up and you kind of fall down in a slow fashion, you put your arm out to break the fall and you break your wrist, that's a fragility fracture. A stress fracture is a type of fragility fracture as well. So if you're in a certain age group and you get a fragility fracture, by definition, you have osteoporosis. A T-score on your bone density scan of negative 2.5 or more, you have osteoporosis. A T-score of 1 to negative 2.5 and a high score on your FRAX score, which we're going to get into, you have osteoporosis. There are secondary causes. There's different ways to image it, but the T-score is based off of the bone density scan. The FRAX score we're going to talk about in a minute here. Blood work, you can't really diagnose osteoporosis off of blood work, but it can give you a picture into your bone health. If you get diagnosed with osteoporosis, osteopenia, you do want to do a bunch of blood work to determine why do you have it and can I correct it and how would I correct it. So you want to check your mineral levels, you want to check your D3 levels. Basic things like immune function, you want to check your basic liver function. You want to look at your phosphorus levels, very important in bone health too. You want to check how much calcium you're spilling in your urine. So checking your urine calcium and sodium, things like that will help determine why your bone is so weak. Parathyroid hormone, testosterone levels, estrogen levels, thyroid levels, all of these matter. This is showing you osteomalacia in a child and an adult. This is rickets, actually. So this is when you have such poor bone when you're growing up that your bones don't form properly, and you get, in the knees case, this weird bowed shape because your body has to form along the force load in your body because it doesn't have any tensile or axial compression capabilities. So you lose that tensegrity ability, that ability to exist upright in a gravitational pull. The bone's too soft to do that, and it starts to compress along with the center of gravity here. Malnutrition does this, multiple myeloma, hyperparathyroidism, so on and so forth. Other lab work you can do, if you really think you have celiac disease, that is a cause of osteoporosis because of poor calcium absorption and things like that. So, but true celiacs have anti-endomysial antibody or high levels of tissue transglutaminase. So there's actually very specific parameters that are positive if you really have celiac disease. Just not liking gluten is not the same thing. Checking your bone-specific alkaline phosphatase is important. Looking for an M spike, a protein spike, which is correlated with multiple myeloma. And then making sure you don't have a blood clot disorder. Raloxifene, we're going to talk about, is a selective estrogen receptor modifier. You don't want to be on raloxifene if you have a blood clot disorder. So here's some other risk factors. I'm not going to get into it too deeply, but just look at the drug thing. Aromatase inhibitors, long-term use of heparin, long-term use of warfarin, glucocorticoids. So these people that get repeated spine injections, repeated epidural steroid injections, or people that take repeated doses of steroid for sinusitis or whatever, you're putting yourself at risk of poor bone health. And then there, of course, is a bunch of congenital issues and some nutritional things that we've kind of sort of talked about already. Here's a bone density scan. That's a machine that does it. The graph on the bottom shows you what's called the standard deviations. That's what those numbers come from. So a standard deviation, you don't want to be outside of the negative 2.3 on the downside, because then you're outside of, I think it's like 67%, 99% of the population. You want to be more in the middle of that inverted U. You want to be average or on the right side. Now, you don't want to be too far on the right side because that means your bone's too dense. But basically, if you're within 2.5 standard deviations, you can see on that bell curve, it goes 0, 1, 2, 3. If you're within 2.5, you're in the vast majority of the population. Now, that said, look how close negative 2.5 on the downside is to having very terrible bone health, being very far away from the peak of that inverted U curve. So really, for optimal bone health, I'm not sure what number we're supposed to be looking for because nobody's ever really told us or made it clear. So I think the closer you can get to that mean, to that normal, where you're not even -1, the better. But in terms of the diagnosis of osteoporosis for purposes of health insurance and large database registries, you have to be -2.5 or more to technically have osteoporosis. And this just goes into that a bit more in definition. And they just look at the density of the femoral neck and then the vertebral body and compare it to age-based norms. Every 1 standard deviation increase in the bone mineral density, so the more you get on the outlier of that inverted U curve, remember normals, the middle, the height of that inverted U, the closer you get to the tail end, every 1 standard deviation increases your risk of fracture by 2. So 2-fold fracture risk. But most hip fractures happen to people that have bone within that -2.5. That's what I'm talking about. I don't think we really have determined what is the optimal bone health for people yet. We just know what technically means osteoporosis, and that's even arbitrary if you think about it. Most fractures happen because of falls. So if most fractures happen to the group closer to that midline where you want to be optimal, and most fractures happen because of falls, we really shouldn't be so much focused on drugs for osteoporosis than fall prevention, really. That's what I think, or both. So fall prevention is your best way to not get a fracture. And that means you have to have balance, which means you have to have strong neural connections between your body and brain, and you have to have muscle. Things like Qigong, Tai Chi, yoga, all of these will improve your balance in a very gentle and controlled way to help you prevent falling. So even if you do have osteoporosis, if you engage in these activities, your fall risk will be diminished and you'll be helping your bone health. Other risk factors. So here's just a whole bunch of lifestyle and genetic. I mean, there's a million reasons to have crappy bone, but the primary one in America is a bad diet and lack of exercise. So how do you treat it if you do have it or if you have weak bone osteopenia? Exercise, drugs, supplements. Exercise is a primary way. I showed you a wall sit and a modified wall sit here for a reason. You can do squats and deadlifts with heavy weights like I've showed you, but most of us aren't going to be capable of that, particularly if you've already got osteoporosis. So these are simple ways to begin to build bone, to begin to do resistance training and build muscle. As you get really good at the wall sit, you can do what's called a progression and begin to hold a weight while you do the wall sit. And eventually you're going to be able to do a deadlift. Eventually you're going to be able to do a back squat, a front squat, et cetera, et cetera. Exercise is your primary weapon against osteoporosis. Drugs. We're going to talk about drugs. Supplements. So 1,200 milligrams of calcium, I believe, is what we should all be taking on a daily basis, particularly women. Calcium citrate is 21% elemental. I put calcium citrate because it's easily absorbed in the system into our connective tissue multi. I take it every day personally. So 1,200 milligrams of calcium daily. D3, the optimal level, most people in exercise science, most people that are interested in anti-aging and wellness will tell you that 3,000 to 5,000 international units per day is your bare minimum. The government will tell you 400 to 800 international units is all you need based on the RDAs. So you decide which standard you want to go by. I go by the one for optimal bone health, wellness, and optimal aging. So I take about 4,000 international units a day of D3 with my 1,200 milligrams of calcium. Then K2, MK4 or MK7, you just want the active form. It's easier to get the one made from bacteria that's more easily absorbed and more bioavailable, the MK7. Magnesium, you want about 300 milligrams. Turns out magnesium also helps with muscle pain, restless leg syndrome, migraines, helps your nervous system work better. Why? Because it's all interconnected, like we talked about throughout this talk. Okay, let's talk about the drugs now. So there's anti-resorptives that are used to treat osteoporosis. That's your first tier of treatment. Osteoanabolics are bone building. And then others, strontium ranelate, fluorides, a drug called odonacaltab, and then hormone therapies like testosterone and estrogen. The anti-resorptives are the tried and true first-line, first-tier treatment. These are accidentally discovered, as much in medicine is. This guy, Herbert Fleisch, was actually studying glycolysis, and he wanted a compound that would inhibit the metabolism, so the electron transport chain, oxidative phosphorylation, all of that. He made an analog of a pyrophosphate. Remember, phosphate is a component of ATP, that is the primary energy currency in the body. And then he happened to discover that these analogs of the pyrophosphate he made to inhibit metabolism actually had a very high affinity for bone mineral. Further testing showed that they slowed the bone destruction, the osteoclasts, but they did not inhibit bone formation. And then in 1977, the FDA approved the first drug form of this, atidronate. And then the bisphosphonates started out. So this is about the 1960s, 70s, people started taking these things. What I tell my patients is that bisphosphonates will hold you where you are. They're not going to make you better, but they'll hopefully keep you from getting worse. There are, of course, some side effects, and we can discuss those if there are questions. The anti-resorptives are stable analogs of inorganic pyrophosphates, okay? They're taken up by the osteoclasts, which we've talked about extensively, and they bind to the bone. The first generation of drugs did not have a nitrogen molecule. The second generation does, and then they work a little bit better. Very essential to osteoclastic signaling. One of the contraindications is this white picture that thins out and tapers in the center. That's an esophagus with a barium enema swallow. That's showing an esophageal stricture. For some reason, these drugs do something with the esophagus, and if you are coming to it with an esophageal stricture, you can't take these drugs. And one of the if you know anybody on Fosamax, you know they have to take it with an empty stomach and they can't eat for 1 to 2 hours after. These things have dramatic effects on the GI tract and are very inconvenient, to say the least. And a lot of people fail them because of these side effects. And then we'll go on to why what you would take if you do fail it. So the bisphosphonates are alendronate, which is Fosamax, ibandronate, ricindronate. So anything that ends with onate is probably a bisphosphonate. Zoledronic acid is one of those injection ones. It lasts a little bit longer, has the highest binding affinity and the longest half-life, okay? They've actually started to notice in different studies that these bisphosphonates don't just affect bone health, but they actually treat depression and anxiety too. Remember when I told you before that osteocalcin matters for mood? Probably there's an osteocalcin connection here, but also if you're inhibiting the osteoclast, you're decreasing the rank L expression, which is highly associated with inflammation. And we now know that most depression and mood disorders have to do with brain inflammation. And again, back to my harping on the same old thing, if you could control your overall systemic levels of inflammation, then you could control almost any disease process you can think of, to include depression and anxiety. So it turns out bone drugs, discovered in the 60s, are helpful for mood in the brain. The monoclonal antibody group of drugs, Prolia, one of the viewers had a question about Prolia before. This is denosumab. It targets and binds to rank L. And now you know what rank L is. That's the ligand that attaches to the rank receptor that turns on the osteoclast. So if you can target and bind that rank L, the ligand, the key, and keep it from fitting in the lock, then you're inhibiting inflammation. You're inhibiting osteoclastic formation and function. And so you stop that decoupling between the osteoblast and the osteoclast, and you switch the balance from heavy on osteoclast to heavy on osteoblast. So Prolia has actually been shown to add bone mass over time. The bisphosphonates do not do that.
Her question was, is there an alternative to the shot?
Is there an alternative to a shot? If you have osteoporosis, like diagnosed, negative 2.5 standard deviation on the bone density scan, or a fragility fracture, I'll be honest, you probably want to be on a drug like this until you at least get to the osteopenia level. Now that said, none of these drugs work and none of them are FDA indicated without also being on D3 and calcium. But I don't think they've ever studied, and I could be wrong, and I'd be happy to do a lit search if anybody wants me to. I don't think they've studied Prolia versus straight up weightlifting, or weightlifting with calcium and D3 and eating things like natto and taking K2. Nobody's really done that because, again, nobody's really known about this till recently. There is no alternative to Prolia except the drugs that we're talking about. So I'm giving you all of the alternative pharmaceutical ways to treat osteoporosis. Raloxifene. This is what's called a selective estrogen receptor modifier. So estrogen has multiple receptors throughout the body, and there are now drugs that can block some of these receptors, but not all of them. So you block some of the bad aspects of estrogen, but you keep the good ones, like good bone health, things like that. So raloxifene is going to help you have estrogen work better on the bone, if that makes any sense. Side note, I put this picture in here to show you there's some very creative off-label uses of raloxifene being used in the weightlifting world. And some guys are taking this to reduce gynecomastia. So you know the guys that tend to form what look like breasts, but it's really just fatty deposition that they don't want there? They'll take raloxifene to diminish that activity, which is very, very interesting to me. Not an on-label use, not recommended, but just to show you how selective these receptors for estrogen can be. Trade name's Avista. Forteo, I've put plenty of people on Forteo. This increases bone mass by stimulating bone formation again. It mimics the intermittent production of parathyroid hormone that your body does. So most hormones aren't constantly produced, they're produced in waves. Forteo mimics the wave of parathyroid hormone. And when you spit out parathyroid hormone, that hormone tells your body to form bone, not to destroy bone. So teriparatide is the trade name, and stimulates the renal production of active D3, another activity of the hormone. Increased intestinal absorption of calcium, another activity of the hormone. Increased reabsorption of calcium by the kidneys, so you're not spilling urine into calcium into the urine. Remember, I told you that's one of the secondary blood tests or urine tests you can do. Like all of these drugs, Forteo only works if you have a normal D3 level. So again, yet another reason to supplement with D3. And then there's other drugs similar. If you've had prior radiation of your skeleton, that's contraindication. Avinity, romosozumab. These names are ridiculous. Avinity is a trade name. A monoclonal antibody that binds to and inhibits sclerostin. Remember, way back in the beginning of this talk, I told you about sclerostin. Sclerostin inhibits WNT signaling and therefore increases the activity of the osteoclasts. So, if you want fewer osteoclasts, You got to inhibit sclerostin. This drug does that for you. It's a dual acting drug. It will not just stop osteoclastic activity or resorption of bone, but it'll help the osteoblasts be more functional and deposit more bone. So Avidity is one of the newer generation drugs for osteoporosis. Here's the algorithm your physician should be following. We'll just skip over that. Any problems with these drugs? Well, of course there is. There's actually a paradoxical increase in fracture risk if you're on long-term use of bisphosphonates. So I've treated people that get a fracture just below the femoral neck in a high stress zone or a high tensile zone of the femur, because although you're stopping the osteoclastic activity, again, with bisphosphonates, you're never really adding any more osteoblastic activity. And so the bone can become weaker in certain high tensile zones. So remember the tensegrity? So that side of the femur that's involved in the muscle pool, people tend to fracture through there. That's with a few years of use. Nausea, discomfort eating, that's one of the primary risk factors of these bisphosphonates and other bone health drugs. Jaw necrosis, a very minuscule risk, but it is a risk. And then cost and coverage, of course. The cheapest, freest, healthiest, safest way to increase your bone density and bone strength is to exercise. Here's some very esoteric labs you can check. I check these on my patients sometimes if I think it's indicated. There's different breakdown products of collagen you can look at to see how much bone destruction is going on. And then there's products you can look at that show you how much bone formation is happening. So fragments of type 1 collagen you can look at. This is if you're trying to see if a fracture is healing or if you're looking for real subtle evidence of changes in bone health. And also you can use these drugs to see if, these labs to see if the drugs you put someone on are effective. Again, more labs you can check, bone formation markers like we talked about. So these are secreted by osteoblasts. The number one thing I check in some people is osteocalcin. Remember I told you that most people that break their bones are not in that osteoporosis category? And I told you that balance is hugely important. So one thing that you should do if you think you're at risk of this, or if you have a family member that you think is at risk of this, is get them tested for fall risk. Physical therapists do this. So you can do what's called the Berg Balance Scale, and it's a 14-item performance test, highly correlated to fall risk. The timed up and go test. So oftentimes when I'm in clinic, I will make someone get in a chair and get out of a chair themselves. It appears like I'm just not helping them, but I'm actually watching and observing to see how they get out of the chair and how quickly they do it. This test, you rise from a chair, walk 10 feet, turn around and sit, and you should be able to do that in under 10 seconds, really. If you can't, you're at elevated fall risk. And then there's a few others. And then the functional reach test is interesting. So this is to see how far you can reach with your feet planted without falling. Obviously, you want to do this against a wall or with assistance. And then rapid side-to-side stepping. So multiple different ways to test balance. And if you find that you have diminished balance, then you're at fall risk. And you're more likely to get fractured with or without osteoporosis. So I would say, first work on your balance, then work on your bone health. The big problem with the bone drugs we see in clinical practice is nobody actually takes them properly. Only about 30 to 40% of patients prescribed these drugs take them as they're supposed to take them for as long as they're supposed to take them. Most people don't like them because of the nausea and the discomfort eating like we talked about. Most people are scared of the side effects. And then this is almost universal. If they're not interested in supplements and good health like you are, because you wouldn't be watching this webinar otherwise, they're probably not taking the calcium and the D3 that is mandatory to take with these drugs. So they're not working anyway. And then there's atypical fracture risk with long-term use, and then the jaw necrosis like we talked about. But that is with massively high doses. They use these drugs to treat cancer. Those are the people that get jaw necrosis. They thought at one point there was a cancer risk with Forteo because of a stimulation of that WNT signaling. And that elevated level of WNT signaling has been associated with many different types of cancers. However, this has been looked at in post-marketing studies, and the FDA has now said the risk of osteosarcoma, if you use these drugs for more than 2 years, is really not there, and they remove that warning. Most of us still only let people stay on it for 2 years because most insurance companies only cover it for 2 years. But technically, you are allowed to take it longer than 2 years now. Rebound fracture is a problem with taking these drugs. So there's actually a higher fracture risk for you if you are taking these drugs and then suddenly stop taking them. So basically what we do, if you find you have a risk factor or a problem with one of these drugs, we don't just stop it. We usually switch you, taper you, or give you a holiday and then start you back up on something. And then meanwhile, you can monitor all that blood work I talked about. The breakdown products of bone and then the products of the osteoblasts that indicate bone formation. And then they've actually done AI studies on this, artificial intelligence, and found that 8 years of therapy with a bisphosphonate is adequate to prevent fractures for the duration. So you really only have to stay on a bisphosphonate for 8 years per this one algorithm, and then you can stop. And then treatment with osteoanabolics, which are better drugs, I think, is 1 to 2 years. So why should you care about osteoporosis? We talked about the massive importance to cognition and bone health. But if you fall and break your hip, 15 to 20%, some studies say 30%, will die within a year of a hip fracture. Okay? 30%, some say a little bit more, will die within 2 years. Breaking a hip is a harbinger of death. So you don't want to get a hip fracture. So again, work on your balance first, work on your bone health second, then start exercising, build your bone mass. Better bone is a better brain. Osteoporosis is linked to dementia in many studies coming out recently. A lack of exercise is linked to dementia. Exercise is linked to good bone health is linked to exercise, and exercise and good bone health are linked to good brain health and less risk of dementia. The mechanical forces on the bones stimulate the production of the osteocalcin, which is a hormone that then talks to the brain. The osteocalcin helps BDNF form. You get better neurons, better synaptic connections, more neuroplasticity, better formation of memory, better cognition. And then vitamin D is also massively necessary for neuronal health. And again, D3 is necessary for bone health. It's all connected. So just so you know, 20 to 30% prevalence, we think, of osteoporosis in this country. Now, I'm pretty sure 20 to 30% of your friends and family are not on drugs for osteoporosis or have not been diagnosed. This is how underdiagnosed it is. Using new criteria, so if you're over 50-year-old and you get an DEXA scan, men and women, we think it's at that 20 to 30% level. If you're 80, the prevalence is up to 80% almost are osteoporotic. This is why the older people seem frail and seem to lose cognitive ability. They've got to get their bone health better and their muscle health. The biggest advertised problem with osteoporosis is fracture risk, and your lifetime risk in men is 20%, so 1 in 5 will get an osteoporotic fracture. Almost 1 in 2 women will. More common lifetime loss of years. In other words, a more common way to shorten your life is to get an osteoporotic fracture. So we don't want that. It's more common than losing lifetime by cancer. The cost of osteoporosis is massive, so if you care about things like that, getting this under control is going to help the country. But for you, it prevents your risk of death because it prevents your fracture risk, and it helps you with your cognition, your healthiness, your happiness as you get older. If you're a woman over 65, you have to get screened. If you're menopausal over 50 and or with a risk factor, you need to get screened. Men over 70 should get screened. Only 9 to 25% of people that should be screened get screened. Thus, it's underdiagnosed. Only 2% of men do. So there's a bunch of osteoporotic men walking around, you probably know some, and they're never gonna know it, and they're never gonna know why they can't remember things properly because they're never gonna go get screened unless you maybe encourage them to do so. Only 20 to 30% of those presenting with a fragility fracture, remember where you just fall over and break it and there's no high energy behind it, were screened by a doctor before or after that fracture was treated. Now that's sad, that's on us. Worse, 90% of people with a fragility fracture never got treated for bone health after the fragility fracture, meaning the doctors didn't treat them, even though we know that a fragility fracture means you're osteoporotic. And then guess what? Almost half of them went on to get another bone break. We have some newer technology I'm not really going to get into, but this tried and true right now, the most covered thing is a DEXA scan. This is a FRAX score I told you about. You can do this online yourself. Just Google FRAX, F-R-A-X, Go back. You answer these questions, you put in and it does a calculation. Now, I sort of did a pseudo me, and I wanted to show you one thing that's different on it. Everything's the same between both. On the left, my major osteoporotic fracture risk is close to 8%, and my risk of hip fracture is 1%. On the right, it's far lower, 3.7%, 0.2%. The only difference is I said I had fragility fracture in the left side and not on the right side. Now, I broke my wrist when I was in Afghanistan, but I was playing indoor soccer on a wet court in the winter and running at a high rate of speed, trying to get the ball from going out of bounds, slipped, fell, and landed on top of my wrist. That's high energy. But if I didn't know that, I would have thought, oh, I had a fragility fracture, and then miscalculated my risk. So the FRAX score is a good tool, and it's something you can go do now on your own, but it's not a perfect tool. Okay, people ask me, what supplements can I take along with exercise, of course, to repair and build bone? Vitamin K is one of the more important ones that we all forget about. Unless you're eating a ton of natto, like we discussed, which I don't, or aged cheese to an exorbitant amount, which you don't want to do that all the time either, you probably should be taking vitamin K2. So we have one that is in olive oil, which helps it absorb easier, and olive oil is naturally anti-inflammatory as well. So it's got 500 micrograms of K4 and 200 micrograms of MK7, and then 400 milligrams of extra virgin olive oil, of course. Now, this is going to reduce your risk of atherosclerosis while at the same time helping your osteocalcin function better for the proper mineralization of your bone. K2 isn't talked about enough in America. Again, it's indicated for osteoporosis in Japan. I take K2 because I know that it's going to help my heart health and my bone health. And even though the government doesn't recommend it as a form or a way to treat osteoporosis, I do because I believe all the basic science studies. So I think K2 is a good place to start. But probably the basics is going to be calcium and D3. So let's talk about that. The connective tissue multi and the CBD multivitamin that we have are two ways to get everything you need for not just proper bone health, but proper immune health too. So calcium, about 360 elemental calcium carbonate in this actually, and then calcium citrate in the connective tissue multi, about 1,200 milligrams. Remember I told you that's what I take on a daily basis. Magnesium, also important for proper mineralization of bone, 300 milligrams. Vitamin C, which is important for collagen fiber cross-linking and is a cofactor for collagen formation, about 1,000 milligrams. D3, about 3,000 international units. I'll supplement and take more sometimes even. I like to go up to about 4,000. And then zinc, which is a cofactor for many, many enzymatic properties of the immune system and really the whole body system. But the connective tissue multi and the multivitamin here is going to give you your calcium, your magnesium, your D3, and your C, which we didn't really talk about, but it's very important for that connective tissue, the tensile aspects of your tensegrity functions. So K2, the connective tissue multi. That's what I would say start with for bone health. And then exercise, so resistance training. You've got to build muscle. And then if you remember from the talk, don't just build muscle, but also work on your balance, because most people that break their bones have normal, they're not osteoporotic bone. So you have to have good balance, then work on your strength, and then, also take supplements at the same time. These are typically what I take. I take the connective tissue multi on a daily basis and the K2.
This lady was RA negative, but she's on methotrexate for chronic inflammation. What are your thoughts? Repeat the question.
RF negative. Okay, sounds like somebody's rheumatoid factor negative, but was put on methotrexate for chronic inflammation. So she must be on it for some rheumatologic condition. I'm not sure which. So methotrexate diminishes your ability to absorb vitamin B, and it's one of those inhibitors of vitamin B metabolism. You probably need to be supplementing with vitamin B. And of course, again, all of this is for education and entertainment. I'm not making treatment recommendations. Please go check with your own physician before you start taking supplements. But methotrexate, I have some patients on methotrexate. Most of them don't really like it. but it's necessary in some rheumatologic conditions when other things don't work. It is a tried and true drug. It's been around forever, but it does have side effects, one of which is altered vitamin B metabolism. So you probably at least need to be on a B complex. Okay, so this is a question not related to really the bone health talk. I'm sorry. The question seems to be, what natural anti-inflammatories can I take for my rheumatoid arthritis? So the answer to that is tart cherry extract, turmeric, ginger. There's a lot of basic science studies that show some effects of CBD on inflammatory modifiers. The FDA is telling me I'm not allowed to say that. PEA is a very good anti-inflammatory molecule, palmitoyl ethanolamide. I would definitely be on that. ALA is going to help the neuropathic components of any rheumatologic condition, so it's a good antioxidant for nerve pain. And most people with rheumatologic conditions are at risk of neuropathy, believe it or not. So PEA, ALA, tart cherry extract, turmeric, off the top of my head, that's what I would take for anti-inflammatory capacity for rheumatoid arthritis. Now, and forgot the most important one, omega-3, fish, I take that every day. I take 2 to 4 grams a day. Omega-3 is massively anti-inflammatory and in fact has been studied in rheumatoid arthritis and other rheumatologic condition and is very good for reducing inflammation in those conditions. Caveat, most of those studies, they're taking it with their methotrexate or with their other drug they're on. But it is a way to prevent and modify the bad effects of rheumatologic conditions. Now, just so you know, for the past 2 to 3 years, I've been working hard on this book that's getting published in May called Bone on Bone. The reason I called it that is I want you to self-treat and get as better or as good as you can get orthopedically and health-wise to avoid walking into a doctor's office, be told you're bone on bone, and get a metal and plastic sandwich or a total joint replacement. What I mean is, I want to empower you to have great health without people like me. And I'm giving you the tools in this book, sort of a lifestyle way of being, a protocol to follow that's relatively easy, step by step, but if you can't do one step, you can skip to the next step. Eventually, you want to be doing everything that I say in the book, but it's a way to treat yourself naturally, to reduce inflammation, reduce oxidative stress, improve your bone health, improve your muscle health, and then ultimately your brain health, of course, and your health span. What is health span? The number of happy and healthy years you get to spend on the planet Earth. So we don't want to just live forever in like a coma, right? We want to be happy and healthy. This book is going to be sort of a guide to help you do that. Bone on Bone is available for pre-order right now. And I sure hope you get a copy, if not for you, but for people in your life that you care about that have these problems, that have pain, that have stiffness, that wonder why they're forgetting things, that are at fall risk, that you know have osteoporosis or you know are weak and fragile and have limited muscle ability. The people that are constantly feeling fatigue, that just feel not right every day, gastritis all the time. All of this, in my opinion, comes down to lifestyle and diet choices and is easily modifiable. And I also give a guidance in the book on certain supplements to take. If you're unable to eat 9 different fruits and vegetables every day, as would be recommended on the Mediterranean diet, and I discuss these diets as well. So Bone on Bone is my way to allow you to sort of always have a guide, a book to go back to refer, to help you self-treat, to avoid surgery, to heal your pain naturally. So hopefully it'll be helpful for you and your family and friends. And again, it's on pre-order. Okay, that's the end of this month's webinar on osteoporosis. And hopefully you guys have learned a few things about osteocalcin, about how bone health equals brain health, and how important getting your bone health is to maintaining your ability to have an optimal health span.